Good morning, everybody, and welcome back to Journal Club. Today we'll be discussing the eagerly anticipated FFFRor MI trial, which was published in the New England Journal of Medicine. And today's presenter is Rossella Ruggiero, Interventional Fellow from Maria Cecilia Hospital in Italy, and we're joined as our expert is Professor Gianluca Campo from the University of Ferrara. I hope you enjoy the discussion and looking forward to your participation. Thank you.
Multivessel PCI guided by FFRor angiography for myocardial infarction. So let's start saying that, as we all know, FFR is actually considered the best tool for the evaluation of coronary stenosis in the setting of chronic coronary syndromes, and actually it is considered it's put in class 1A of the current guidelines of myocardial revascularization in this setting. And this class of recommendation is derived from results of many trials in this topic. However, when we consider acute coronary syndrome, the data are not so solid, let's say, because these are the two main randomized trials that have been published regarding the STEMI setting. However, despite the use of revascularization, use of FFR for the revascularization of multivessel and non-culprit lesion, this trial evaluated compared two different approaches: the culprit-only revascularization versus the complete revascularization. As we all know, the complete revascularization per se demonstrates to reduce the cardiovascular outcomes even with the angiographical evaluation of non-culprit lesion, as demonstrated from the results of the complete trial. Therefore, there was a need for this study to evaluate if use of FFR in the STEMI setting could be a better tool than angiographical view for the detection of non-culprit lesion and for the cardiovascular outcome. The aim, as we already said, of this paper, this trial, is to compare the FFR versus the angiography, the primary for the evaluation of non-culprit lesion. The primary outcome is a 1-year occurrence of death from any causes, non-fatal myocardial infarction, unplanned revascularization. Therefore, patients from 2016 to 2018 were prospectively enrolled at 41 sites in France. The inclusion criteria are very simple. STEMI patient who underwent successful PCI of culprit lesion, defined as more than TIMI2 flow in the culprit vessel, and a stenosis residual less than 30%. And also multivessel disease with involvement of one major epicardial coronary artery or a side branch more than 2 millimeters with at least 50% of stenosis. Exclusion criteria are here reported and are covered. Overall, 1,100 patients with STEMI and multivessel disease were enrolled, who underwent successful PCI of culprit lesion, and then when randomized to FFR-guided revascularization and angio-guided revascularization. The complete revascularization of non-culprit lesion was performed with a media of 2 days from the culprit lesion treatment, even if the author suggested to perform the revascularization during the primary PCI. In here we can find the characteristic of the population. More or less the characteristics are the same for the two groups. Those are young patients, not so many diabetic patients, and also the characteristic of presentation are more or less the same for the two groups. Here we can find the lesion characteristics. Even also in this, also these characteristics are more or less the same. I just want to point it out the fact that in the FFR guided revascularization group, the median of mean value of FFR were 0.79, 16% of lesion, the data were missing, and no FFR, post PCI FFR basically was performed for these patients. And these are the results. At 1 year follow-up, no differences between the two groups were evaluated, were found. As we already said, the primary outcome was a composite one from death from necrosis, non-fatal myocardial infarction, unplanned hospitalization leading to urgent revascularization. And as we will say later in the limitation, the value of the number of events were very, very few. Also, no differences in terms of secondary outcomes was observed. The authors also performed a subgroup analysis, and no differences were observed between the different groups of evaluated. So the authors, these are the limitations of studies proposed by the authors, suggested by the authors. They, as we already said, find out a very low than expected rate of events. And also they find out that as a limitation, the completeness of revascularization was not performed by a core laboratory, but was relied on investigator evaluation. So the authors conclude saying that there is no differences between revascularization guided by FFR compared to angiographic evaluation in the considering the occurrence of death, myocardial infarction, or urgent revascularization at 1 year. Before starting the discussion, I just want to point out which are the characteristics of a STEMI patient compared to stable patient that can influence the FFR results. Because as we know, during the acute coronary syndromes, there are a lot of, these are the main factors that could influence and could lead the FFR to be not reliable for our aim to evaluate the stenosis, non-culprit stenosis. And in here, in this meta-analysis, were reported, first of all, the neurohumoral activation, the distal embolization, the raised left ventricular and systolic pressure, and endothelial dysfunction. And therefore, the question is, these are some of my questions. And first of all, I don't know if FFR as a functional evaluation in this setting is the best tool. Maybe QFR, maybe IFR could be a better tool to evaluate. And also, as some suggest, should we postpone the functional evaluation some weeks after the pulpit lesion, just to make the microcirculation to rest after acute coronary syndrome? So I conclude my presentation.
Okay, thanks, Ross. It was a very nice summary and overview of the flower MI. I think you've got some nice discussion points, which we'll come to in time. But before we address those, can I call Prof. Campo, if you can just give us some of your, let's say, insights and comments specifically about the flower MI trial, firstly, and then also where, in your opinion, this trial fits in the wider field of multivessel physiology when it comes to STEMI and other trials that we have. Thank you.
Thank you, Arif. So regarding the flower MI trial, I have two major comments. So the first comment is regarding the rationale behind the trial. If you analyze the major aim that allow the introduction of a physiology-guided revascularization in our daily practice is the application of physiologies as gatekeeper procedure to guide the revascularization of lesion. So when you perform FFR or IFR, any physiology tool for the discrimination of a lesion, your aim is to decide if perform or not the revascularization. So when you compare FFR guided strategy against angio guided strategy, your aim is not to improve the outcome, especially in the specific setting of multivessel disease, but to achieve a similar outcome as compared to angio-guided procedure with less procedure, with less stent, with less treatment. So to achieve a similar result between angio-guided and FFR-guided PCI in a multivessel patient, I believe is a great result because you perform less procedure, you implant less stent, and you achieve a similar outcome in the medium term. So because in this trial, the outcome is at 1 year. Why FFR can be better in the long-term outcome? Because if we analyze a very complex population, probably performing less, not crucial revascularization in a first time, you can induce less periprocedural MI. And we will know that if you perform a huge periprocedural MI, you can have a long-term impact in the outcome. Again, when you implant less stent, is probable that you will achieve less adverse event, not only at 1 year, but also in the longer follow-up. But to achieve this result, you need to enroll a very high risk population with complex lesion and with an important rate of adverse event. And this is the second comment regarding the FFRor MI trial. If we analyze the statistical analysis and the sample size calculation, the author suppose an primary outcome at 1 year around 10%. And as you well know, the outcome in this trial has been very lower, around 4-5%. So in this case, we have a very huge probability to be underpowered to demonstrate any outcome. So my major issue regarding this trial are related to the rationale. Why at only 1 year in a very low risk population, FFR should be superior as compared to angio-guided. And the second is, if you want to demonstrate the superiority of a tool as compared to another tool, you need to respect your sample size calculation. So you need to enroll a population around 1,000 patients if you have a rate of adverse event around 10%, as you suppose in your first analysis. So this trial is very complex to understand because you have few events, and probably if you can see some difference, you cannot appreciate with this kind of population. This is my major two comments. I don't know if someone want to add additional speculation about this.
And then any comments about where the field is with respect to multivessel physiology?
Regarding multivessel physiology, I believe that if we take the question of Rossella, you will know that we have some trial. Recently, an important paper on JAK cardiovascular intervention has been published comparing the outcome of FFR guided against IFR guided procedure in patients with acute coronary syndrome. We can suppose that the resting index could be better as compared to FFR. In particular, as you well know, there is a huge proportion of patients receiving intracoronary adenosine in the FFRor MI trial, and probably this could increase the number of patients without adequate hyperemia. So I believe that when you have a multivessel patient, physiology-guided revascularization is a wonderful tool, but your aim, you can prefer FFR or IFR. Probably resting index are more helpful and easier because the data are more consistent across country, across operator, across cath lab. If you perform FFR, you have to induce very well hyperemia. Otherwise, your result is not good. It can modify the finding, the interpretation of the data. And in this case, is different the aim that you have. You want to achieve a good revascularization in your patient, limiting the number of stents, limiting the vessel that you treat.
Okay, thank you.
Sorry.
So maybe now would be oh,
sorry, there is Julia.
Good morning, everybody. I have
sorry, my connection is gone. Okay, go. Sorry.
Theory. One question for Rossella and one question for Gianluca. Rossella, could you please explain to us the procedural details of performing FFR? So the FFR was performed during index procedure, and the PCI of the non-culprit vessel was performed during index procedure or after some days, and then repeated FFR. I did not understand.
The FFR was performed. Allora, the author suggests to perform the FFR during the index procedure, but at the end, in the results, the operator performed the procedure complete, the vascularization of non-culprit lesion, and so on the FFR the day of 2 days later. Then
it was a mean period, 2 days.
2 days.
I mean,
okay, more or less 2 days, mean period, yes.
Okay, so I ask Gianluca, how should we act with this patient? How should we manage this patient? We have to reevaluate them after some days, how many days, and then decide what to do?
Yes. In daily practice, you have to be it's necessary to have a good compromise, because we have to manage the patient without increase the hospital length. So obviously we have a lot of data suggesting that in some patients, not in all patients, in some patients, we can have an impairment of the microcirculatory system. So if you perform FFR, you can have higher value with the probability to miss some functional lesion needing PCI. So if you postpone probably just 1 or 3 days, so you perform the evaluation after 4 days, 5 days, this is not enough. So if you want a total recovery of the system, you need to wait 30 days, 40 days. And okay, if we analyze the data from a previous study, for example, the complete trial showed that you cannot see any difference if you complete your patient angio-guided, because in the complete trial, the revascularization was angio-guided in the large majority of the patient. You cannot observe any difference. But from a practical point of view, this is not good for our patient, because you need to conclude the revascularization and the management of the patient in the index hospitalization to start as soon as possible the secondary prevention and the normalization of the life of the patient. So in my suggestion, this is my daily practice. Now you have two different options to manage this patient. The first is to perform a resting index. So resting index probably are really better in the first days after an acute event. The second option is to perform a complete physiological evaluation of the patient, adding CFR, IMR to FFR assessment. And now we have a very practical tool, for example, Coroventis from Abbott. In the same time, you can perform in the staged procedure, FFR, IMR, and CFR. And you can have a whole spectrum of the assessment, and then to guide your revascularization with a wall analysis. The other opportunity, as Rossella told you, is to use the angio, the index, so the images of the index procedure to perform QFR. Is another option. I believe that the best way is to use the available tools that you have in your cath lab to optimize the management of the patient. And probably we have a lot of data suggesting that the angio-guided revascularization can be really improved if you use QFR, IFR, FFR. So the best outcome for your patient if you support your eyes with another tool.
Okay, so we can conclude that thanks to the flower MI, we understand that FFR, EFR, physiology-guided PCI could help us to treat better our patient, to decide when to stent or do not, and reaching the same outcomes of angio-guided PCI with lesser number of stents. So we probably better, longer follow-up. But about the timing, we have no answer yet. Any other question?
There is Professor Giannini.
No. So good morning, everybody. Thanks to Rossella. I have a question for Gianluca and all of us. So the rationale to treat non-culprit lesion in STEMI setting for me could be to treat lesions that are at high risk for further events and to reduce the myocardial ischemia. So for myocardial ischemia, we know that probably if we treat myocardial ischemia, at least in the chronic setting, we know from the ischemia trial, we do not improve ardent points. So my question is, here is a different setting, but we are still talking about stable lesions. These are stable lesions that may cause ischemia. We can detect ischemia by FFR, but why I have to expect an improvement of outcome because I've reduced ischemia, even if it's a different setting? This is my question. So I guess that probably we can reduce ardent points by treating lesions that more likely will get unstable and will be cause of further cardiovascular events. And there are ongoing trials that are evaluating intracoronary imaging in the same setting. So STEMI patient, successful primary PCI, then a detection of the high-risk lesion, and then to evaluate if the stenting can help. My question for Gianluca is the right tool physiology in this sense? So in reducing events by treating with stent vulnerable plaque, or intracoronary imaging could be the best choice.
This is the crucial point. When you perform a complete revascularization in an MI patient, your aim is to reduce the burden of adverse event, obviously achieving two complementary events. So the reduction of MI due to unstabilization of plaque, and reducing the need of a further revascularization for residual angina and symptom. When you analyze the available data, in particular, for example, the sub-study from the complete trial with OCT, you have very interesting data suggesting that probably the lesion that can give in the first year, in the first 1 year and a half adverse event, are lesion with a lot of plaque burden, and not lesion soft plaque with other markers. If you analyze the sub-analysis from the OCT complete sub-study, the large majority of the adverse event were linked to plaque with a lot of plaque burden, with important stenosis, with calcification. So probably lesion that we can detect also with coronary physiology. If you analyze also the data from the Prospect 2 trial, you have some data suggesting the same thing. So probably data with a lot of plaque burden are more probable to give event in the first 1 year, 1 year and a half. Obviously, physiology cannot be the perfect tool to detect any adverse event, but could be all the paper from FFR and IFR suggest this, can be the good gatekeeper to select the lesion with a higher probability of adverse event in the first 1 year, 1 year and a half. And on the contrary, could be a very good gatekeeper to exclude lesion with a low probability of adverse event in the long term. So if we have to achieve the total identification of lesion requiring revascularization, probably we have to mix physiology and the imaging. You will note that there are a lot of companies working in this direction, combining IVUS and physiology, OCT and physiology. By now, if you want a tool to do the large majority of the identification, probably physiology could be better as compared to IVUS and to OCT.
Okay, are there any other questions, either regarding the actual paper, the Flower MI trial, about the study, or specifically about the field of physiology in this setting? I would encourage people to ask questions because we really do have somebody who is doing a lot of work. Can you hear me?
Now, yes.
Okay, sorry, no, I was just saying, if anybody has any further questions, now is a good opportunity, because we really have a real expert in the field who's not only doing this on a daily basis, but actually is involved in a lot of the research. So if you have any questions, practical questions, research questions or ideas, please, now is a really good time to share them.
I'd like to know from Gianluca what he does in his clinical practice, simply, when he routinely uses physiology in multivessel disease after primary PCI. Exactly what do you do, Gianluca?
As you will know, our strategy, we have a double approach. So the first approach is to use the images from index procedure for QFR computation. And the second approach is when we perform a staged procedure to perform a whole screening of non-culprit lesion with CFR, IMR, and FFR. This is now our standard approach for the non-culprit lesion in the setting of MI patient. So when we have a good discrimination by QFR, we use QFR data from index procedure. If we have some trouble or some doubt, we proceed after 3 days. Our mean time is 3 days with a complete physiology discrimination of the non-culprit lesion. At the moment, this is our tool. As you well know, we are working also in some sub-study from the FILE trial, trying to match OCT finding, IVUS finding, and full physiology finding, and probably we will have new data to support this approach.
Okay, but do you do that just when you have some lesion that you can simply treat with stent? Let's say that you have
no. It's totally the contrary. If you want to be a good physician, your approach should be totally opposite. So you have a patient with multivessel disease, you identify the culprit lesion, and you have the non-culprit lesion. The non-culprit lesion, as identified by visual estimation, has a stenosis major than 50%. So your approach should be independently to complexity of the lesion. You have to perform a first gatekeeping approach with QFR. So if QFR is really negative, you can be confident that the patient is safe, and you discharge the patient without any other further intervention. On the contrary, if you have some doubt about QFR analysis, you cannot perform QFR analysis, you take the patient again in the cath lab after 3 days, independently to complexity of the lesion, you perform a whole screening of a physiology tool, so CFR, IMR, and FFR, resting index, and you decide to complete or not the revascularization in agreement with this data.
Okay.
And this is true for proximal LAD, for very complex lesion. Obviously, the missing piece is chronic total occlusion, but this is a total different topic.
But let's say that you have right coronary artery myocardial infarction, very simple lesion, and the diffuse disease on the LAD that you will never treat with a stent. You already know. So why you should have all this information if finally what you can do is simply to give optimal medical therapy? And these are most of the patients that we see in our clinical practice. So when I treat a patient with myocardial infarction, most of the time, it's true, I can have a focal lesion on the circuit, but most of the time I have some diffuse disease. Maybe I can treat just the proximal LAD, but I leave most of the disease in the mid-distal LAD. So we still don't have evidence that we give a benefit by treated with stent this patient. So why I have to get all this information if finally what I can give to the patient is simply medical therapy?
Yes, Francesco, but remember that the prognostic information and the diagnostic information is really important for the patient. If you have a patient with diffuse disease, and the diffuse disease is associated, for example, with a poor or a low physiological level, for example, a low FFR, a borderline FFR with an increased IMR, a low CFR, I believe that this information is really important for the management of the patient to avoid, for example, stress test in the follow-up, to avoid misinterpretation of the symptom, to avoid to repeat coronary artery angiography. Because if you give a very well description of the coronary situation of the patient, you can write in your discharge letter, the patient has been treated on RCA. Please note that is present a diffuse disease in distal LAD. This disease can induce some symptom. can induce alteration in stress test, but this disease cannot be treated with PCI. So please avoid to perform stress test, manage very well the symptom of the patient, and please be careful with the patient because the symptom can be not associated with a poor prognosis. So if you manage very well the patient with the therapy, the prognosis will be good. I believe this is a very important information for our patient. Also to avoid so that the patient is not happy, so go to another physician, repeat coronary artery angiography, go to another physician, repeat nuclear stress test. So to avoid this, this is very common in patients with multivessel disease.
And Gianluca, what about the risk of a peri-procedural MI in case of a complex PCI of a non-culprit lesion in an already injured myocardial?
Yeah, Julia, this is a great question because, as you will know, if we induce a huge peri-procedural MI, we have a prognostic implication. And probably this is one of the potential benefits associated with FFR-guided revascularization. However, if you want to highlight this benefit, you have to enroll in the trial complex patient. If you analyze the risk profile of the flower MI patient, probably this patient have been excluded. So you cannot observe the benefit from the action as gatekeeping of physiology. But this is the crucial point. The crucial point is if you have a real-life population with a higher risk of peri-procedural MI, of higher risk of contrast-associated kidney injury. So probably in this kind of patient, to select the revascularization based on physiology can improve the prognosis because you avoid peri-procedural MI, you avoid renal failure. This is an hypothesis because we have few data about this. But for example, when you move from a randomized clinical trial to a real-life registry, the Florida data that now will be available very soon, you observe a benefit in terms of mortality in a patient with acute coronary syndrome and elderly patients. So probably when you move from low risk to high risk population, a gatekeeper approach can be associated with a better outcome. We need to collect more data about this specific topic, I believe. This is very important.
Okay, thank you. Any other questions for anybody? I appreciate we're coming close to time, so we'll probably have time for maybe just one more question, and then we'll conclude the session. So anybody has a last question they'd like to ask? If not, then Prof, I would like to ask you, what's coming up next in this field? Let's say with multivessel physiology, what do you know of any major trials that are coming up that we can look forward to that will guide us a bit better or give us a bit more information?
Okay, now I believe, okay, as you will know, we are working on the 5 trials, so comparing by is quite different from flower MI because it's complete revascularization against culprit only in an elderly patient. In this field, I believe the sub-analysis from the Florida registry in a patient with MI will be very interesting. We have some anticipation on Twitter, on scientific session, but now we will have as soon as possible the paper. I believe that could be very helpful to compare the benefit from FFR and angio-guided approach in real-life population. And obviously, I believe that we need a larger trial. As you will know, the authorship from the complete trial is trying to achieve the possibility to perform the complete 2. So it's like flower MI, but in a larger population. And probably if they are able to enroll in a complex population. And the other missing piece that is really important is the flower MI in non-STEMI patient, because non-STEMI patients are really different, because probably you can have some trouble in the identification of the culprit lesion, but in the large majority of the cases, you can identify the culprit lesion, and you have more frequently more comorbidity, older patient, multivessel disease, and a comparison between an angio-guided and a physio-guided approach could be very, very interesting. In this topic, we don't have any data because previous study mixed the possibility to treat culprit lesion and non-culprit lesion, inducing some wrong finding.
Okay, thank you. I think that's a perfect way to conclude the session. So thank you very much, Rossella, for presenting the Flower MI, a really important study. Prof, thank you so much for, I think, answering all the questions, your advice and guidance for this field, and everybody else for contributing and your questions and comments. So I think we had a very nice session. I think a lot of us understand a bit more about what we can do, what we should do, and also perhaps moving forward, what we need to do. So great. Looking forward to next week, next Friday. Join us again. We'll be having our next journal club, and we'll be shortly advertising the topic and the speaker. So have a good weekend, everybody, and see you next time.